Hello, my name is Nicole Fitzenreiter, and today I'm going to be discussing evidence-based practice. Now, you might be wondering, what is evidence-based practice? Does my provider even use evidence-based practice? And how much experience do they have with it? Today, we're going to go ahead and we're going to look at what it is, who's using it, and maybe how they're using it. I went ahead and interviewed two other athletic trainers. The first athletic trainer is Kristen Maniak. She was my preceptor while I was at San Diego State. And then I went ahead and interviewed Tom Abdenauer, who is an NATA Hall of Famer who has been practicing for over 35 years. Now, Kristen and myself both learned from Tom, and while Kristen does not nearly have as much expertise as Tom in her 8 years of athletic training, I feel like she truly understood what evidence-based practice was. And then I also got to hear from Tom to kind of realize how evidence-based practice has evolved over his 35 years as an athletic trainer. We'll go ahead and look at these next videos of the interview with them, and then I will also discuss kind of what I learned throughout these videos and discussions with them, more or less. And I will tell you my overall opinion of evidence-based practice and how I'm currently utilizing it in my practice. Thank you.
Right, perfect. So really quick, how about just tell me a little bit about yourself, Tom?
Okay. I'm still a certified athletic trainer. I had 38 years of experience as a head athletic trainer at the college level or at the professional team level. I'm fortunate to have received the Tim Karen Award, which is the highest individual award from the NATA. And that was in 2005, 2007, NATA Hall of Fame. I've been the president of the State of Utah Athletic Trainers Association, the chairman of the National Basketball Athletic Trainers Association, and I love to publish and write, and I'm working on a textbook right now. So even though I'm quote unquote retired, I'm on the NATA Foundation board and working on this book to keep me busy.
So thank you for taking the time to talk to me. I really appreciate it. I guess let's just start with a little bit about yourself.
Okay. So I'm Kristen. I have been in the profession for 8 years now. I have my undergraduate in athletic training, my master's in rehabilitation sciences, and then I just finished my doctorate in December from A.T. Still University.
That's awesome. Congratulations, Dr. Kristen.
Thanks, Nicole.
So I'm sure over your last 35 years, I mean, you've probably seen evidence-based practice kind of evolve and change and everything like that. So tell me, what do you think evidence-based practice is?
I think where we've come, let's go with where we were when I was in your spot.
Absolutely.
When I was in your spot, evidence-based practice was really simple. Did it work or not? And what was the definition of did it work? Did it work from the standpoint that the player played, that they came back for more treatment? We really didn't put a whole lot of science or scientific beef behind the decisions that we made. We all studied from textbooks. We all attended lectures. We all read journals. But in some cases, we still did things that were kind of on our own that seemed like they work. Fast track that along the way to the push toward evidence-based practice and the definition of what it is. So I've seen that evolution come, and there's still some old timers like me that have trouble comprehending what it all is. So it's all part of the evolutionary process. So that's where we were then. As I see it right now, evidence-based practice still incorporates a lot of that old school thinking that we had. Did it work? But now we have the scientific basis and rationale of why it worked. And I think one of the classics on that is ultrasound. There's a lot of us who used a lot of ultrasound along the way and still do. But 1.5 centimeters for 5 minutes and move that thing around like you're on a pinball machine, that might not have been the best. And now I think there's a big debate, does ultrasound work or not? If so, is it with phonophoresis or not? So I think that's one of the areas that a lot of people have still some debate with regard to, well, it seems like it works because it helps. It helped. Okay, well, maybe there's no scientific basis behind it. Yeah. So I think that's one of the areas that, again, is kind of a jump ball, so to speak.
Okay.
Awesome. All right. So we're going to talk about a little bit about evidence-based practice today. And I guess within that, what do you think evidence-based practice is, or what is it to you?
So I'd say I know a lot about it now, so I could give you like the real definition of the three different aspects of evidence-based practice. But I guess more practically, I think a lot of people don't realize that it occurs on a daily basis and we utilize it within our practice. And it's not just looking up research, but involves patient interactions and feedback, as well as our previous clinical experience, and anyone around us previous clinical experience as well.
Yeah, no,
So-
absolutely. I think when I was kind of doing some research, I always just, or before I even knew really what it was, I was like, oh, you just like find research. And I didn't know there's this whole like clinical expertise that is part of it as well, that it's not just research all the time. And whatever research says, you kind of have to use your background as well.
Yeah, and I think the patient interaction is really important too. Like asking for patient feedback. Did you like the treatment? Did it make you feel better? Did it make you feel worse? And then applying that to whether you utilize that in your practice again or not. As well as, a lot of patients don't think STIM works. The research isn't great on it either. So, but if a patient thinks that it does work and the research isn't good on it, I'm still going to use it because they think that it works. So.
I know that you're not in the clinic anymore, but obviously you're still writing a book and everything like that.
Right.
So, how do you utilize evidence-based practice? Let's say even maybe when you were in the clinic, did you utilize it? And then now that you're outside of the clinic and doing something different, are you utilizing it and how?
Well, let's go back into the not too distant past. And this is one of the papers that we tried also. In the NBA, we had a fair number of players who sustained quote unquote bone bruises, where they would be kicked in the foot or they'd sprain their ankle and end up with an intra-articular bruise. So we looked to see how in the world can we try to resolve this, because they were painful and they were long lasting and they were a nuisance. On a scale of 0 to 10, their effectiveness as an athlete was a 7.5 or an 8, which meant that yes, they could play, but they were compromised. So we tried to find a solution for it. So we did a literature search, which is a key component of evidence-based proof. And we found the use of a medication that normally women would use in osteoporosis that applied toward bone marrow edema pain relief. And lo and behold, we used it on 3 of our NBA basketball players, and it worked. So that's one area where we got into the literature. We came up with an idea, kind of the PICO question, and lo and behold, we hit gold. Secondly, one of our doctors that I worked with the Warriors uses a different medication for that women use for osteoporosis and fractures, usually in their back, for non-union fractures or other bone stress injuries. And it's an application of a medication that's not necessarily designed or intended for elite young athletes, that works on elite young athletes. So those are 2 indications right there of kind of out of left field ideas that you can go to the literature and see. Now, there are other evidence-based concepts that we can use. For example, in your post-knee surgical rehab, how do you know when the return to play decision should be kicked in? What's the proof of the pudding? Is it the calendar? Is it that the doctor says it's okay? Is it girth of the quad muscles? Or is it some kind of a functional test? Is it balance? Which is it? So again, going back into the literature and finding out what you can find and then applying it is something that we've done along the way. Did that a lot at San Diego State with regard to our return to play decisions on lower extremity issues.
Okay, all right, that's great. And I guess when you're kind of doing your research, what do you use? I think Medline is pretty popular. And then like kind of the search. I know when I've kind of started researching and going through kind of my PDF files, talk about like meta analysis and all these different types.
Right.
Is there anything like specific that you look for?
Like that the search engine of choice for me is PubMed.
PubMed, okay.
So I'll go in there and type in this bizarre connection. The one, like I said, that we found for the bone marrow edema, in the basketball players was a search of bone marrow edema and bone mineral density.
Okay.
And I swear only one paper came up. Maybe there were a handful, but not many. And that came out of Germany. So that's worked well with me. And then once you get in there, then you can follow the bouncing ball.
Yeah.
Say, okay, fine. I've read this article. I like reference 6 and 12. Okay, what's reference 6 and 12? And then just kind of connect those dots that way. So
Okay.
it works out well.
How are you utilizing evidence-based practice kind of in the athletic training room?
I think so. In undergrad, I feel like we didn't really get very much on it, even though it's a standard. I had no idea what evidence-based practice was. I also think that the fact that you need evidence-based practice CEUs has kind of put a damper on what EBP is, and that people have a poor perception of it. So I try to talk about it a lot in my practice now that I understand what it is, from not only, asking my patient how they're feeling and then making an adjustment based off of it. Why take a subjective if you're not going to change what you're doing based off of that subjective, as well as teaching my students and letting them know what evidence-based practice is and kind of destigmatizing that negative stigma of EBP.
Yeah, no,
So that's
absolutely.
kind of how I
Absolutely,
use it. I'm big on research, so I do research. I read all the time. But I think with research, you have to figure out how you're going to apply it. Does it work in your patient population? And so I do read a lot, but I don't think that's as applicable as, what I've previously done for a hamstring strain, because it works. It might not be in research, but it worked on all my other soccer players, so I'm going to use it again.
Yeah, no, absolutely.
Back when you were at my level of my career,
Yes.
were you kind of practicing evidence-based? And I guess now over the last 30 years, do you feel more prepared for it? And how has it kind of evolved, and how do you feel where you were now, before, to where you are now actually utilizing it?
I will say this: back in the day when I was in your spot, this might be not the most precise use of the word best practices, but that's what I practiced.
Okay.
I practiced based on the best information that we had.
Yep.
When, for example, when to use ice, when to use heat, when to use contrast, when to use stretching, when to refer to a physician, based on textbook information, based on lecture information, for example, at the NHA convention, based on literature and journals, and based on discussing with physicians and colleagues and things like that. Being inquisitive, say, how can we skin the cat better? And then it's just advanced and still maintain that way, just from the standpoint of still going to the literature, still learning from journals, still, again, talking to physicians, even now, about different things. So that fundamental concept is still there.
When do you feel like you become the most prepared for evidence-based practice? Would it be through AT still? I mean, obviously you're saying you didn't really get in your undergrad. So I guess how did you become prepared, and how do you feel prepared now?
Yeah,
to 5 years ago?
I literally had no expertise on it until I got into my doctorate. And the first class we took was EBP, which is the same as you're doing, right? And I mean, the first thing that I said to you when you said you were taking EBP is, well, I'm really excited for you to take it and actually understand what it is and how to utilize it in your practice. And I think that that was a great knowledge that I learned within my doctorate. So I think all of my knowledge that I received was from AT still, and I think that was invaluable, what I learned.
Do you feel like there's any barriers that evidence-based practice kind of has? I know that as it's very popular kind of maybe more in like physical therapy or within like nursing and other healthcare providers. And is there any barriers with athletic training? I've seen that we work with a very specific type of individuals, and sometimes there's not, there might not be evidence for a specific case. Do you ever find that that's true, or, you know, as we continue to utilize it and do more evidence, that you're actually able to find resources and research?
Well, I think right now, Nicole, you are in a generation that is being taught in particular with regard to evidence-based practices versus when I was your age. Like I said, we just went with the best of information that we had available. So it would be natural for you to stick with what you've been taught and expand from there. Barriers within our profession, there are many, and they apply to things in general. Or the competitive athlete, and that's what I'm going to stick with, the competitive athlete, more so than the other emergent settings that we are involved in. But the competitive athlete who has a return to participation based on a calendar. We have a game tomorrow. We have a game next week. We are in spring football right now. We only have a limited number of days. You can't take that time off because, or they say, I have to return to the game. So those are kind of barriers that are just inherent with sports medicine. There are also barriers from within, relative to, this is the way I've done it. You can't teach an old dog new tricks, and I don't really want to learn.
I guess kind of like within EBP, and especially within athletic training, because obviously I know I've heard of EBP kind of more within like nursing and other things like that. Do you feel like there's any limitations within athletic training because we work with such specific populations?
That's an interesting question. I don't think so. I think a patient is a patient, and I think the limitation would be within the clinician themselves, limiting themselves as to how they utilize it or if they utilize it. You see so many people ask a subjective and then not adjust based off of that subjective. Well, that's not utilizing evidence-based practice, which if we want to be represented as healthcare providers, we need to do.
A very skilled clinician educator with all the letters behind his name said that the non-ice fad is not evidence-based science. Okay, then push comes to shove, and we have to get that athlete ready to play tomorrow. Are you going to say, no, don't bother icing it? Or are you going to revert back to what you've known as best practical information and say, yeah, they're going to put a bag of ice on it?
Yeah.
So, like I said, I'm not in that school, so I don't know.
Yeah, but I think the more that I'm kind of learning about, I mean, I've always kind of thought evidence-based was just the evidence, but within evidence-based, there also has to be, the clinicians, like the way that they do things. I'm trying to think of the word, I just can't think of it. But
it's their gut feeling.
Yeah, just just the way that they do things. You take the evidence, and then you also are going to evaluate the evidence with your own thoughts and your own tricks.
Right.
And then
exactly.
And I think that's where at least I've thought, even in the last week, I just thought it's just evidence and that's all you could look into. But then again, too, you have experience. You take the clinician's experience and you kind of mold it together to then determine, okay, well, am I going to apply this or am I not? And then after applying it, well, then let me think about how it went. And not every time it's going to go well, but that doesn't mean that it hasn't showed you that it's not a good option.
Absolutely.
It's not about it. You did it work, and yes, it worked. That's great. But if it doesn't work, well, then that's allowed you to evolve and realize, well, I'm not going to do that next time because that didn't work.
That's exactly right, Nicole. Because again, what I've talked to my contemporaries who say, oh, that evidence-based nonsense, I'm going to just do it my own way. And my response to them was this: if this was 30 years ago, you'd been all over it, because it's still the best information that we have. Plus you go into the literature. And again, from the scientific, from the researcher standpoint, who may not be clinicians, things have a different perspective possibly than what we see clinically. But it's the skill, and that's where the art of athletic training comes in, where you can kind of blend the science with the everyday.
I remember this article. It's probably one of my favorite articles. I print it out for my students now. If you should look it up. It's an editorial by Dr. Eric Sowers.
Okay.
And he talks about what evidence-based practice is, how it created this negative stigma through CEUs, how it's properly practiced and how currently it's not being properly practiced.
Okay.
It's very easily readable. So it's good for my students who don't get the knowledge of EBP. And probably, like I said, one of my favorite articles. And so I think that really opened up, what it is and how it can really be clinically applied rather than just reading an article and trying to figure out what from the article you can take into your practice.
Yeah, no, absolutely. Yeah, I think you're talking about when you talk about the CEUs, and now we have evidence-based practice CEUs, and you're kind of like, oh, like, what am I going to do, And I think you're right. It definitely has that negative stigma to it. And the more that I'm kind of learning about it, there's so many different kind of domains about it that it makes it kind of unique. It's not just what my perception has been.
Yeah, I mean, we use it on a daily basis.
Yeah.
Like
Yeah.
literally daily in your clinical practice. It's crazy to think, right? I mean,
yeah, like you don't even know that you're doing it.
Has anything kind of maybe taught you like, wow, maybe I shouldn't be doing this, or and maybe again it's a case by case basis, right? Because not
Right.
everything that works for one person is going to work for the second person.
Right.
But I think again when I was reading kind of quote unquote cons about of evidence based, they were exposing maybe some information that we're starting to learn is maybe not like kind of like talking about the ultrasound.
Yes.
And a lot of people don't like that, that's
Right.
kind of a challenge to their practice and their integrity and everything.
Exactly.
And I mean, I guess, have you seen that, and how are other providers and yourself, utilizing that information?
Right. In addition to ultrasound, which is again a little controversial, and there are purists that say it does absolutely nothing. And then there are others that say, well, it's worked for me for years. And then there's somewhere in the middle where I say, okay, fine, maybe it's worked well on superficial tendinitises, for example, rotator cuff or patellar tendon, in conjunction with a medication that we can deliver versus just ultrasound gel for 5 minutes at a continuous wave. Others are going to say, no, we've learned that pulsed ultrasound is better than continuous ultrasound. So I think that's a way. Secondly, you got to look at this one through a rose-colored glasses of sorts, or tinted glasses, and that's the Cybex Biodex isokinetic machine. All right. When I was your age, that was the hottest thing going. Everybody wanted to have them, and we're going to do knee extension and flexion tests at 60 degrees, 90 degrees, 60 degrees, 180 degrees, and 270 degrees per second. Boom, boom, boom. That's what we're going to do. And then we realized a couple of things. I'm not sure which was the chicken and which was the egg. That in ACL rehab, the patellofemoral joint was getting grinded up and irritated by doing open chain knee extensions on an isokinetic machine. So maybe people stopped using those on the clinical side in sports medicine outpatient clinics. And then in turn, insurance companies start paying for them, the bills. That no longer became a billable idea. At least that was the way I understood it. So now all of a sudden, that testing is gone by the wayside. We're not going to do any Biodex or any Cybex testing anymore for our open chain extension because insurance company doesn't pay for it, or because it trashes the patellofemoral joint, maybe. But bottom line is, which way are you going to skin the cat? Those things like that. But we've learned so many things along the way that are grounded in evidence. Again, from an evaluation standpoint, the role of functional evaluation. I think that's tremendous. And in that process of a simple squat, we've also learned of the role of the hip abductors. We've learned of the role of the collapsed foot, tight Achilles tendon. And all of those lead to a more comprehensive, thorough evaluation, makes us better professionals.
It really made me listen to my patients more and, realize like, okay, so I have been doing this for long enough to know that a soccer player with an adductor strain, this is what works. But it doesn't work for every patient, right? So you give it a try first, and then you get feedback from the patient. The patient says, okay, well, that I'm not getting better. I need to play soccer. This is not helping. Great. So we're going to switch it up. Like, oh, one might respond better to cupping than Graston, same basic concept of what you're doing, but one patient might make them feel better than the other.
Yeah, absolutely. I think kind of centers back to that patient-centered care kind of. It's all about the patient. And that sometimes I think in your undergrad, you're just kind of going by step-by-step basis is like what you know, and you're not really taking in the holistic approach and what the specific patient goals are and making it all about the patient.
Yeah, I agree. And utilizing that whole person healthcare aspect, right? So what is that whole person? Like, how can you take the whole person into consideration? Whether that's their mental health of the day, whether that's, they're a starter and they need to play tomorrow. How are you going to take that patient feedback into consideration?
Now that you've heard from my colleagues about their information on evidence-based practice, I'd like to go ahead and kind of take this time to reflect on what I've learned in hopes that maybe you might understand now what evidence-based practice is. So to start with, what is evidence-based practice? And to be totally honest with you, before talking to my colleagues, I totally thought that evidence-based practice was research. In my undergrad, just like the discussion with Kristen, there's this negative stigma about evidence-based practice because there was only one day in one of our courses and all they did was show us how to use Medline and research databases. They didn't really go too much into it. They just said, oh yeah, this is how you do research and you grab this research, then you write a paper on it. And again, there was this negative stigma about what it was. But now, since I have gone through the readings and I've talked to Kristen and Tom, I've learned that research is only one aspect of evidence-based practice, and it's a huge combination between research and clinical expertise and patient values. Without one of these, two of them, all of them, without any of them, you will not utilize evidence-based practice. You need to have all three in order to be considered practicing evidence-based medicine. How do I utilize evidence-based practice in athletic training? And how much experience do I have with EBP? Truly talking with Kristen, it kind of helped me understand that maybe I'm utilizing some form of evidence-based practice. Now again, don't get me wrong, because again, you have to have all three components in order to use evidence-based practice. But I didn't really even know that maybe I was trying to use evidence-based practice correctly without even knowing it. So every day I take into action what has worked in the past, and determining on if that past was successful or not, it might change my decision. So for example, the use of modalities with my patient, it might be because research has showed it's helpful, or it might be, well, there's not a lot of research and more research has maybe shown this is kind of useless. However, my patient is getting a positive response and my patient values this modality, so therefore I will use it. Maybe that research doesn't clinically show how important it is, or even if it is important, but in that moment, patient value is going to go ahead and rule over research. My clinical decision will be to utilize that modality. When it comes down to specifically using all these three components of evidence-based medicine, I truly believe I've used them. I have not used them conjunctively. So I might have used one or the other, or maybe two at the same time, but I truly don't know if I've ever used all three of the components since my clinical rotation starting in 2013. And lastly, do I feel prepared to practice EBP currently? And to be totally honest with you, no, but in the last week of learning about it more and more, I'm more eager to try it. I am more eager to give that patient-centered care and optimal patient care to my patients using EBP. Athletic trainers, when we talk about 10,000 hours of each skill, athletic trainers have so many skills, and it's going to take me probably a lifetime before I can become a clinical expertise at each of these skills. But with that going forward, even after I probably obtain those hours, evidence-based practices can continue to evolve, and it's going to continue to get better and stronger, because in the end, it has one goal, and it's to give patient-centered care. So I would imagine that even when I do obtain these hours, I'm always going to want more. I'm always going to continue to think, you know what, you don't need 10,000, you need 12,000. And then I will never be satisfied with being average or being that clinical expertise. I want to have I always strive to continue to learn more, do more, be better. I never settle with one specific goal. So I think that as of right now, do I feel prepared? No, but I'm sure in the next 2 years going through this DAT program, my confidence in evidence-based practice and the way that I utilize it will only continue to grow and help my patient in overall patient care. Thank you.